Hey, good morning, everyone, and welcome to EuroNurse. We meet every Saturday at 9 a.m. Central Time. And hey, by the way, happy Nurses Week. If you're watching us on YouTube, great, LinkedIn, or Facebook, we come to all three of those now. Glad to have you on board. Be sure to hit that subscribe and like button or the share button if you're on Facebook. Like to get all the information we can about you. And if this is your first time visiting us here on EuroNurse, be sure to check out our website at euronurse.com. That's where you can find out lots of information about the show. And it's also the best place to go to watch all of our past episodes. And we've got 41 episodes in the bank. Woo. Hey, if you're interested in sponsorship of the show, be sure to hit that sponsor info button to learn more about that. And you are the ones that drive the show. We, no matter how you're watching us live, are able to get your comments through the comment box. So if you've got a question, go ahead. However you're watching us, feel free to put those comments in the comment box because we're going to answer your questions. We've got a great show for you today. This week, we're going to have Jason Alter speaking, and he's going to be talking about the advances in early prostate cancer detection and risk assessment. He's from Exosome DX, so I'm looking forward to a really interesting talk from him. And let's go ahead and bring in our experts right now. Alrighty. So great. For those of you that don't know who I am, my name is Vic Sinise. I'm the host and producer of EuroNurse. I've been involved in urology for well over 30 years, and this was my way of being able to pay it back and kind of help educate folks in the urology field. Our guest speaker for today is Jason Alter. Go ahead and introduce yourself.
Oh, thanks, Vic, and thanks for having me here. My name is Jason Alter. I am the head of clinical and scientific affairs for Exosome Diagnostics. I've been in the prostate cancer world with prognostic and predictive testing for about 20 years since its inception, and I'm happy to be here today.
Great. We're glad to have you on board. And Andrea, go ahead and introduce yourself.
Hi, my name's Andrea Strong. I'm a nurse practitioner in Wisconsin. I've been working in urology since 2010. I worked as a nurse for a long time. I did inpatient, I did outpatient. I'm also certified as a urology registered nurse, and I'm the educational director for the Chicago Metro chapter of SUNA. So thanks for having me today.
Great. Always glad to have you on board here. Let me just take a quick look at our comments here. And let's see. Andrea, let's go ahead and have you kick off the show with your favorite story. Again, this is where anybody out there wants to throw any comments or shout outs or anything like that. Go ahead and let us know those things. But Andrea, go ahead.
I have a special announcement this week. I've decided to run for board of directors for the National SUNA board. And, throughout my nursing career, I've had so many wonderful mentors, people who were supportive, encouraging, who genuinely wanted to see new nurse practitioners, new physician's assistants, new nurses succeed, and for experienced nurses and healthcare professionals to succeed. SUNA really has embodied the spirit of collegiality and education, and I want that healthy learning environment to continue. And that's one of the reasons I've decided to run for director at large. So the goals for the position that I'm seeking will be communication. I want to enhance communication among SUNA and other professional organizations because I think there's a big opportunity that we're missing to collaborate with these organizations, such as the WOCN, SUFU, AUA, the Urologic Association of Physicians Assistants, the Oncology Nursing Society. Another goal I have is inclusivity. Our organization should strive to be inclusive and welcoming to members of our community, all members of our community, regardless of their background, identity, or beliefs. Innovation, we should innovate using new technologies, evidence-based practice to make sure that we stay at the forefront of our field. Financial stability, we really need to maintain that and practice transparency with our members. Collaboration, as I've already discussed, there's a big opportunity to collaborate with other professional organizations and join the conversation nationally and internationally when it comes to urologic care for our patients. And accountability. We need to hold ourselves accountable for making sure that we're delivering the highest quality of care. So I hope that you would consider me a candidate for director at large. Voting doesn't start until July 1st. So thank you.
Hey, that's great. I wish you all the best of luck. And as I kind of mentioned earlier, that in Chicago, we have a saying, vote early, vote often. But yeah, definitely I want all the fans out there to support Andrea. Got a comment coming in from Susie. Awesome, Andrea. So you got fans already, see? All righty. We're gonna go to our favorite stories. Again, if you guys have any comments or stories you want to put in on the we got more comments coming in. Nancy says, congrats, Andrea.
Thank you.
You got, like I said, you got a fan base out there. You'll have plenty of support. I'm going to lead off with mine because I've got a little bit of a presentation to give. First thing I'm going to do, I got to bring this up. I got this from, I hope I try to hold it up here so everybody can see it. It's all fun and games until someone loses a wiener. Now, this came in the mail from Amazon. I didn't order it. So I don't know if I got a fan out there who thought I needed something along this line or what. If you did, let me know. If you did, thanks. If you didn't, Amazon, thanks. But hey, you get crazy things in the mail, right? So that was my little interesting thing. Let's see here. I'm going to pull this up now. So I just want to ask a question to the audience. What's missing in this? And if you figured this out, it's you. Too many buttons. There's an opportunity to become a panelist. We always can use more people. We've got a great group in here, and I love having them. But this is what drives the show, is having the panelists. And I was talking with John Lynn, who's one of our panelists on a pretty regular basis. And he said, one of the things we probably should do is promote that more, because people might be nervous about becoming a panelist. Well, don't be nervous. What do you need to become a panelist? I like at least 10 years of experience in urology. That's good. A willingness to share that experience, and video and audio. If you've got it on built into your computer, great. You're all set to go. What you don't need a degree in computer science. Folks, this is easy, especially with the new StreamYard system. All you need is a browser. You don't have to have any special software. It's very easy to be a panelist. I don't expect a weekly commitment. If you're able to come on a regular basis, that's great. If you're not able to come on, if you want to come every week, even better, but we don't need that. And you don't have to buy expensive equipment. Good video equipment is necessary, or is usually included in most computers nowadays. Audio, you can see that all of us use an accessory mic, a USB mic, but they're not that expensive. A good $17 on Amazon will get you a great mic and really make your sound a lot better. What you're going to get out of this is confidence in public speaking. Maybe you've ever wondered, could I present? Could I do a talk? This is a chance to test it out, see how you do when you speak in public, because you can always watch yourself back, which can be scary, but it's good. Meet exciting people, enough said. And most importantly, it's a chance to pay it forward to a great career that you've had so far. Easy to do. Just go to the uronurse.com website, hit the join button, fill out that quick little form on panelist, and you'll be able to submit your information on the form itself. So that's my favorite story for today, is to try to get you guys to be a panelist. If you're thinking about it, try it out. You could just, be sitting in the square and minding your own business, and suddenly, I know the answer to that. And that's your opportunity. So don't be afraid to be a panelist. Give it a try. We hope to get you on board. Now I'm going to go ahead and bring Jason in here, because you want your slides for this, right? For the favorite story. So let me bring those in here. Add that to the stream. And good. So great. You are set to talk about your favorite story and then go right into your presentation.
Great. Well, I am here to talk today about advances in prostate cancer early detection. Thank you, Vic. Thank you for inviting me again for us to speak. And my favorite story, I'm going to shift to this slide. I'm a magician, and usually I will do, instead of a favorite story, I'll do some magic for the audience. I can't do that here in this forum. But I will tell you that at the Western AUA last year, which happened to be held in Hawaii, I was seated at a table with a bunch of different urologists, and I didn't think I'd have much in common with a couple of the doctors there that I just met for the first time. And it turns out that the doctor next to me started doing magic, and I'm a magician. So we started doing magic, and the entire dinner, the two of us did magic for the table. We became great friends. And about 2 months later, he invited me to join him at the Magic Castle, where he's a member in Los Angeles. And this is an old Hollywood mansion that is by invitation only, where you serve a fabulous dinner, and then you get to experience magicians. Some of the best magicians in the world are performing in small, close settings throughout the mansion. So this has always been a dream of mine, and I'd never been there before. And through this chance meeting with a urologist, we were able to go and experience it. And he's still a good friend. So that's actually my story that I thought would be relevant for this morning.
Yeah, that's really neat. I thought I recognized the castle. The big organization for magicians is called the IBM, which stands for International Brotherhood of Magicians, which I was a card-carrying member for years. My uncle, who got me into magic, was the president of the IBM at one time. So I
really
got to see. I never got to visit the castle though. So
no, it is an experience.
Yeah,
very much so. Well, so I am a magician, and I also do birthday parties. So I put that plug in, but I am based in California. So I'm going to just start now and go on with what some of the goals this morning are. First, going to go over.
Jason, can I
Yes,
ask
sir.
you a favor to make that full screen? Go to that screen on the bottom. Or
I can do that. I am only afraid that the translation will still go. But hold on one second. That's why I didn't do that. But hold on, and I will turn on the slideshow. And let's see if it still translates. It's still translating.
I gotcha. If you hit that CC button, that red CC button, it should turn it off, I think.
Oh. I think that might have done it.
All right.
Thank you so much. So I appreciate the technical support as well. So today we're going to cover what exosomes are, if you've never heard of them, the clinical need for a test that is based on them, the ExoDx prostate, also called EPI test, how the test works, why it's different, some of the data that's behind it. There's quite a bit of data, but I'm going to summarize it briefly this morning, how this works in case studies, and a little bit of a summary. So the three goals that I hope that people take away from this morning's discussion, if nothing else, because there is a lot of information in these types of presentations, is the first, that this test is really based on very novel science, a lot of very solid data that's been published. It resulted in it getting into the NCCN guidelines, and recently the AUA updated guidelines in Chicago about 2 weeks ago, has Medicare coverage. But the second important point is that this is really unique because most of these types of tests, if you're familiar with any of these, either early prostate cancer detection or tissue-based tests post-diagnosis, all incorporate clinical features, or for the most part do. And the clinical features often are driving a lot of the performance of your testing. So this particular assay does not have any clinical features. It's a simple gene expression test that stands on its own. So it's called standalone sometimes. And then finally, the studies are all designed with very rigorous inclusion criteria that are looking at the most challenging patients for you in early prostate cancer detection, which would be men who are in a very homogeneous, narrow zone called the PSA gray zone of less than 10 nanograms per mil, who are coming in to make a decision with you and other healthcare providers about whether they need either an initial biopsy or a repeat biopsy because they've had a prior negative. So as I mentioned, the EPI test has been featured since 2019 for initial or repeat biopsy in the NCCN guidelines. And then recently, it was added to the updated early detection guidelines from the American Neurological Association. These guidelines were just updated and released at the AUA a couple of weeks ago for those of you who attended the meeting in Chicago. So let's talk about what exosomes are. Exosomes are small bubbles, small microvesicles, and they're really, really tiny. And they're on the order of the size of viruses. Now, when I went to school many, many years ago, and this is a timeline of understanding of what exosomes are and how they're used, most people thought that these types of microvesicles were just junk, waste removal. And over time, as you can look at this timeline from the late 60s through the 80s and now to 2012, which is where this particular timeline stops, it was understood that exosomes don't just remove junk or responsible for waste removal from the cell. They're actually a new form of cell-to-cell communication. And that paper in 2008 by Skog et al., right in the middle of this timeline, is by the founder of Exosome Diagnostics, who's actually one of the top 4 or 5 people in exosome biology in the world. And based on his discoveries that he came up with, the National Institute of Health poured a lot of money into a common fund program, about $150 million, to help drive exosome discovery. And in the 80s, about 100 papers on exosomes were published in the entire decade. And currently, we're publishing something like 40,000 papers per year are coming out. So quite a lot of work is being done. So you can think of exosomes, these small vesicles that are very, very tiny. They're less than typically 100 to 200 nanometers, which is a billionth of a meter. You can think of them as cellular tweets. They go from one cell that produces them to another cell where they're providing information. And they contain RNA, DNA, and protein, and they're very stable vehicles for biomarker detection, which is why they're potentially so useful for diagnostics. And lastly, you can find them in pretty much any bodily fluid that you can think of. And they're not just located in human beings. These are found in pretty much every cell in nature. They're also now known to be involved in a lot of different types of biologic processes. They're involved in normal physiology. They're also involved in oncology. I've listed just a few of some of the hot spots, such as cancer, immunosuppression. They're involved with memory-related diseases such as Alzheimer's. From virus cloaking is one of the ones that's particularly catches my interest, because we sterilize products now to prevent or inactivate viruses as well as bacteria. And it's now known that exosomes can actually shield or cloak viruses and protect them in these types of situations. So there's a definite, as you could see, there's a definite concern about something like that. And then at the very top, I've added space for 2 reasons. One, my son is a rocket scientist, and I always figure a way to work him into a discussion. But the other is that we as a company work very closely with NASA for men on the International Space Station, measuring exosomes for normal physiology, looking at or investigating how gravity, the lack of gravity, affects long-term living in space, in orbit. So we're doing quite a lot with exosomes. We're actually a world leader in this biology. And finally, I used to say that exosomes would be taught as a 5th method of cell-to-cell communication, which is what they seem to primarily be doing, such as the ones you classically learned about in school, such as endocrine and paracrine and so forth. These 4 well-known classical methods of cell-to-cell communication. And recently I've had some medical residents tell me that they've already now read about exosomes in recent textbooks. So this is now known and acknowledged as a 5th classical method of cell-to-cell communication that we're just beginning to understand. So it's a fascinating science. But what's the clinical challenge, and how do we apply exosomes to it? Well, the clinical challenge is really about men who come into the clinic with an elevated PSA, which means specifically somewhere between 2 to 10 nanograms per mil. It could mean over 10, but we have focused the test where patients typically have PSA that's elevated that could either be related to cancer or it could be related to BPH, benign prostatic hyperplasia, where the two are conflated. And what you're seeing here is one of my favorite movies, The Matrix, where the main character, Neo, is offered the choice between two different pills to take them down to make a decision about which way they want to go. And I use this because this has been used in the past by other leaders in the field to describe the choice for PSA. When PSA is the biomarker that we have for screening, and we use that in combination with digital rectal exam to make a decision about whether a man should have a biopsy or could safely wait to have a biopsy. And because PSA is so non-specific, we're never really sure teeing up men. We're teeing up men with the best information we have, but it's extremely limited. And it's extremely limited. And what are the challenges with these biopsy decisions? Well, there are, even though biopsy does not cause mortality, there are side effects associated with biopsy, from the widely common just general pain and some fever and so forth. But systemic infections are a concern because of transrectal biopsies, which is why the field has become much more accommodating to transperineal biopsy. So you don't want to expose men to a procedure that they don't really need unless they truly are candidates because they're at higher risk. But at the same time, you don't want to miss aggressive prostate cancer. And the rate of distant metastasis has been rising for the last 10 years or so, 11 years, or actually since 23 now, it's been going up continuously. And that's in large part been associated with the United States Services Preventive Services Task Force decision on PSA screening that happened in around 2012 and 2013. So on the one hand, we don't want to miss high-grade cancer. On the other hand, we want to biopsy only men who are at higher risk for needing that biopsy. So where does the test fit in? Well, that's where this test, which I'm going to refer to as EPI, comes in. And both these names are appropriate, ExoDx Prostate or EPI. But the test comes in to help men and their caregivers make shared decisions about having a biopsy or deferring a biopsy with more information and better information than's currently available in the clinic. So how does it work? Well, it's a urine-based test that, unlike many other tests that are available out there, does not require a digital rectal exam. There's no DRE required. And because there's no DRE required, I'll advance the slides. Because no DRE is required, this test can either be done in the clinic or kits can be sent to the patient's home, a sample collection kit, which is very straightforward. And the patient mails that back to the laboratory for testing, and the results are provided to the practice. So it's a urine-based, non-invasive test that analyzes exosome gene expression for 3 specific genes, PCA3, ERG, and SBDEF. And these 3 particular genes were selected through discovery because they're associated with high-grade cancer. And what the test does is suggest that patients who might avoid biopsy and which men might have higher risk of high-grade cancer, which is defined as Gleason 7 or higher, and should have a biopsy. In other words, if you're going to find, likely to find a Gleason 6 or a grade group 1 cancer, this test doesn't want to find those patients. This test only wants to suggest which patients upon biopsy you're more likely to find at least a Gleason 7 or higher tumor, and defer biopsy for men who aren't likely to find that. So how does it work? Well, These 3 gene expression are translated to a score that goes from 1 to 100. And based on some data that I'm going to highlight in a minute, we have shown that at a cut point or a threshold of 15.6, any man who has any score up to 15.6, from 0 to that 15.6 threshold, has a very high likelihood of not finding high-grade cancer. And how good is it? Well, I'm going to show you in a second the negative predictive value, but the likelihood is very high that if you're below that, it's not 100%, but it's either 91% for grade group 2 or higher that you won't have it, or 97% for grade group 3 or higher, which is Gleason 4+3, that you won't have it. And as you go above that score, that threshold, the numbers or the incidence of high-grade cancer detected increases. So let me show you how that works. First, I just want to mention, here's where it fits. This can fit in several. Epi can fit in either a primary care setting where men are using, men are coming in for their physicals, getting elevated PSAs. General practitioners are doing digital rectal exams and making decisions about sending men on to urologists. But primarily, where it's been being used today is in the urology office, where the urologist often repeats the PSA and then makes decisions on whether they're going to do a biopsy. And if they find they have a positive diagnosis, then they're going to go on to treatment. But if they don't find something, if they find a benign sample upon biopsy, then typically those men come back for a repeat biopsy because they have a prior negative biopsy. And it's in these settings where you're making an initial or a repeat biopsy decision that the EPI test can provide clinical value to the physician and healthcare practitioner and the patient. How does it work in practice? Well, patient pees into a collection device which captures the first 15 mils of the urine sample, and what we look for is the first part of the urine stream. This is not like when you're doing testing for infections where you want a midstream collection. We want a first catch collection. It doesn't have to be first void of the day, but we would like the patient to wait at least an hour from voiding before. So if the patient just voided, then wait an hour and collect that. We spin the exosomes, these small bubbles, down. We break them open and we do polymerase chain reaction analysis for these 3 genes and translate that to the score that provides you with this result. Now, one of the reasons that this data is so strong is because it's so transparent. So we have a lot of data, but I want to tell you about some of the commonality of the data. All of these studies are prospective clinical trials. And in total, there's somewhere north of 3,400 patients from many different academic and community urology clinics in the US. And we also have work from some European laboratories as well. And the intended use population, where every one of these studies is focused, is really where it's most difficult to understand what the risk is of finding high-grade cancer, which is men who are 50 or older, which is associated with guidelines, the age, with PSAs of 2 to 10. So anywhere less than 10, but primarily 2 to 10 is where this test is designed to be used. And the test, as I'm going to show in just a second, and I mentioned with negative predictive value, has really excellent performance. So let me summarize some of the performance with the first validation study, which was published in the Journal of the American Medical Association. And it's rare to be published with these diagnostic and prognostic tests in a journal of that caliber, but the data is very open, transparent, and quite robust. So a large prospective clinical trial, men all in this very narrow homogeneous zone of 2 to 10 nanograms per mil. And the goal was to see how well this 15.6 threshold worked at discriminating between high-grade cancer, which is Gleason 7 or grade group 2 or higher, and low-grade meaning grade group 1 or Gleason 6 cancer or benign disease, and suggesting which men could safely avoid a prostate biopsy. And when you look at this bar chart, which is area under the curve, which is a balance of sensitivity and specificity, and it's a probability scale, you see that PSA, which is widely used on its own, has area under the curve of 0.55, which is essentially a toss of a coin. Probability of 0.5 is a 50-50 probability. So using PSA to make this decision on its own is really quite poor. When you incorporate PSA with clinical features such as the prostate cancer prevention trial risk calculator, the blue bar, see it increases the area under the curve, but it's still not very impressive. SOC, a standard of care, is really an in-house standard of care model trying to optimize the clinical features that are available. And it's essentially the same as the PCP-TRC calculator. It's not really impressive. You look at EPI, a substantial improvement in performance in helping understand which of these men truly have high-risk cancer that would be found on biopsy. And then when you add EPI with standard of care, which is that gray bar, you see it increases, but only very slightly, from 0.71 to 0.73. And what that really indicates is that the clinical features are not really adding any value to what's already the information that's captured by the genomic assay. And that's why this genomic assay doesn't require any clinical features and is offered on its own because it provides all of the performance metrics that are needed to make this decision. The other data slide that I wanted to show you from these validation studies is this particular chart on the top, which is from a pooled meta-analysis of multiple studies. And what you're looking at is this series of increasing bars, which is the EPI scores going from left to right on the x-axis. You see as the EPI scores are low, less than 10, you have a very low incidence of high-grade cancer. So on the y-axis, the taller the bar, the increasing likelihood of finding high-grade cancer. And so when EPI scores are low, the incidence of high-grade cancer is actually quite low. And as the scores increase, you see that they actually step up. And that's what that's showing is that you're getting an increase in incidence as the EPI score rises. On the bottom chart, you're seeing in that same cohort of men, PSA binned out every 1 to 2 nanograms per mil, or actually every 1 nanogram per mil, up to 10 nanograms per mil, going from 2 to 10. You see that you really can't tell any difference between these various PSA numbers. So while a PSA 8 or 9 you might think is the person to be concerned about, you really can't tell the difference using PSA alone between somebody who has an 8 or 9 and somebody who has a 4. And that's because PSA is so nonspecific. So in the same group of men, you can see the association with high-grade risk that you can see with an EPI score that's simply not present, simply based on PSA in this particular case. The other data slide that I want to show you is quite unique in the field of early prostate cancer detection testing, and this is assessing clinical impact. So in other words, for payers want to know, how does the test help the healthcare practitioner? How does it help them impact their decision? So this was a double-arm randomized clinical study. This was what's called level 1 evidence because it was a double-armed trial where patients were randomized to one of 2 arms. In one arm, what you're seeing here is in one arm, patients would receive their EPI result. So everyone peed in a cup, everyone, we ran the test on everyone, but we only gave the answers back to men randomized to the EPI arm. We gave it back to their clinicians. And in the control arm, the clinicians and the patients got a note back saying, sorry, you're not getting the EPI test result. Please use whatever standard of care processes you normally use in consultation with the patient to make a decision about whether you're going to have a biopsy or not. So this was a direct head-to-head comparison in two arms in looking at how the epi test impacted patient care and physician practice, which is what reimbursement or payers want to see. And so what we found was that there was a significant increase in compliance when physicians suggested their patients not have a biopsy. Compliance in the epi arm went to 92%, which was substantially higher than the control arm. And when physicians, and I think this is key, wanted their patients to proceed to a biopsy based on the test results, there was an 85% increase in compliance. And that was really something that was quite nice to see, because it also resulted in the detection of 30% more high-grade cancer being detected in the epi arm. And that was not expected by us. Essentially, what the test did proved in this particular level 1 evidence trial was that men who didn't need to have a biopsy and could safely wait did. And we actually increased the percentage of men who should not have a biopsy didn't. But we also increased the likelihood of men who should have a biopsy but weren't going to listen to their physicians. Maybe they weren't going to come back to the clinic because they weren't in a rush to have a biopsy. We found more high-grade cancer than in standard of care use because more men complied and listened. And so what epi is essentially doing is improving quality of care for patients. We're deferring biopsies in men that are unlikely to find high-grade cancer, and we're sending more men who are at higher risk to have a biopsy, and as a result, actually catching more high-grade cancer, which is what urologists want to be able to do. They don't want to biopsy men who don't need it, and they want to biopsy men who are likely to need it and to find high-grade cancer when it's present. Now, we recently, and by recently I mean literally 2 or 3 days ago, published a follow-up to this study. And the follow-up is on this slide. There's a lot of data in the study, but I'm only focusing on one point here. And what the payer said to us when the clinical utility study came out a few years ago was, how do you know these low-risk men are still low risk down the line? We want to know what their results are later. And we pointed out that these men are not diagnosed with prostate cancer, but we wanted to know whether the low-risk men still remain low. And 2.5 years later is an interim analysis of a 5-year study. And what we showed, if you look at these red gaps, is that in the epi arm, in both the clinical utility study on the right and the 2.5-year follow-up on the left, is that when your epi results were low risk, which is the green bars, your incidence of high-grade disease 2.5 years later was still low. Whereas if your results in blue were, you had a high-risk result from the test, you had a significantly higher incidence of high-grade cancer found on biopsy. And so, in other words, the bottom line from this particular study was that men who were selected as low risk are still, for the most part, low risk years later after their initial diagnosis. And this is based on subsequent prostate biopsies. So let me show you, as I close out the last few slides, some real-world case studies. So here you have 4 men. These are real patients that I originally selected because their PSAs are very similar. PSAs range from 5.69 to a high of 6.3. The ages are a little bit different. You have from 58, a younger man, to 70, which what I would argue today is still a very young man. We had percent-free PSA information on a few, PSA density on a few, and MRI on only one, which that patient B had a PIRADS 3. And the question is, which of these patients really need a prostate biopsy? And today we're making decisions based on the clinical information you see right here. And it has its pros and its cons, but it's very limited, and it's very hard to tell which of these men truly would require a prostate biopsy. There are some factors that argue for it, such as ethnicity, and then their PSA density. Nobody is really at super risk, depending on where your threshold is for density. You get a little disparate results for percent free PSA. So the question is, how do you really make a decision on this? And I would submit that using the EPI test here, which I'm showing you the results for these men, showed that 2 of these men came back in red, a high risk, and I selected men who were at decent high risk to show you some of the power of this. And the other 2 men who were African American actually came as low risk. If you look at the biopsy row, second from last, you can see that in the benign, the men that were low risk, they both were shown to have benign tissue on prostate biopsy, so there was no cancer found. And in one of the men with the high epi result, you not only found a Gleason 7, you also found a Gleason 9 in this particular patient. So that is the man you want to catch. And then one of the men, patient A, you didn't find any didn't find any cancer. And so I put that there in particular because when you get a high risk result, it's not a guarantee that you're going to find anything, because there's 2 potential answers. One is when you get a high risk result and you don't find something, it's possible the test is wrong, right? Test is not 100%. But the other is that the test is, you're being assessed by biopsy. And so when you assess the test by the gold standard, which is a prostate biopsy, which misses approximately 50% of the cancer, you never know with the high risk score whether the patient, whether the test was wrong or whether the biopsy simply didn't measure that. And we actually do have data from men who had radical prostatectomy that showed that a number of these men that biopsy said were benign with high scores actually had worse disease than it appeared simply based on the prostate biopsy. But that's the practical use. And let me close with one more practical use slide. Here you have 1,250 men. Each bar here is a man, and this is not from our studies. This is just from the lab. And what's common to all these men is that their PSA is exactly 4 nanograms per mil. And so if you have clinical features and everyone comes in with a very similar PSA, and I've taken it to an extreme here with everybody having exactly the same PSA, you really can't tell any differentiation between them with clinical features. Whereas you can see that all the men in blue are the ones that fall below the epi threshold and are the ones who could safely defer a prostate biopsy based on our data, validation data. And as the risk increases above that, you can see that the risk for those men of high-grade cancer being found on prostate biopsy will increase as well. So the conversations that you'll have with your patients at different points in the spectrum are going to be much more nuanced, much more personalized, and provide much more value than when you just talk about the limited clinical features that you have to make that sort of decision. So I'd like to close and open it up for any potential questions. To tell you that, again, this is a non-digital rectal exam, non-invasive urine test that assesses the risk of finding high-grade prostate cancer on prostate biopsy. And it's focused on men in that hard-to-understand 2 to 10 nanogram per mil zone of PSA, considering either initial or repeat prostate biopsy. It's based on a lot of significant data, robust science, a unique exosome platform. And because of more in-depth discussion of the information I've shown you, it's in guidelines, AUA, NCCN, and has Medicare coverage. And with that, I'd like to thank you for your time this morning to this, and I hope you find the presentation useful. Thank you.
Yeah, that was really great. Hang on one second here. Just want to add our final panelist to the group here. Wonderful presentation. It really kind of summarized everything, I think, in an easy to digest way, which is great.
Oh, thank you.
Thank you, Dr. Alter.
It's my pleasure. Thank you.
I'm going to jump in and ask the question that we're all thinking. How much does it cost? Is it covered by insurance? And how much work are we going to have to do to get this covered for our patients?
Oh, actually, and so in medical affairs, I fortunately don't have to answer the toughest question of all, which is usually the salesperson. But I can tell you that for Medicare patients, there's no cost out of pocket. This test is covered by Medicare. There's no patient contribution. The list price, the worst case, absolute worst case, if the patient had to pay the full price, is $995, but we have a number of different insurance coverages across the country. They tend to be regional in different parts. You'd have to figure it out. But we also have a very advanced, what's called ExoCares program, which will let you know if you reach out to the company, call their phone number, or reach out to your local representative. They're the experts on that. And I haven't seen in conversations over the last year or so this program's been in place any issues with payment. Most patients pay something very reasonable out of pocket. I can't tell you, it depends where you are, what that is, but that ExoCares program is designed to help support the patient. So we don't want to penalize patients. And it's a truism that all these tests, when they first come out and are making its way into the marketplace, have this reimbursement issue. But I'm happy to tell you that Medicare is covered. Depending where you are, there's regional coverages. And then there's this Exo Healthcare program, which, at the best of my understanding, has really mitigated any issues with this. But I encourage you to reach out to the company and the local reps who will tell you what's going on in your area.
Does it require elevated PSA because it doesn't use PSA? Is it required to have a PSA before you order the test?
It is. It's required that. So the indications are that, and by elevated PSA, that elevated is such a wiggly word. Elevated depends on what the doctor is concerned about, but that's why the range we have from 2 to 10, any PSA between 2 to 10 is considered elevated, and that's based on where the test was tested in all these populations, men with those PSAs. So I'm sorry, was there a second part, or because I sort of
no, that's the only part I had asked.
Okay. Yeah, no, it's indicated for that. You do have men who say, well, what about doctors and nurses who ask about, what about that man with a PSA of 11 or 12? Does the test not work? Or the men who's 49, does the test stop working? The test works fine for, men that are, a little bit younger, a little bit older, or, greater than 50. It's pretty much anybody greater than 50. And for PSAs, they're outside that range. But the reason that it's in this range and it's covered in this range by Medicare is because this is where it's thought most of the clinical challenge is. And that if you had a high PSA, although it varies from doctor to doctor, many doctors are not going to not do a biopsy. That's not always true, but it was really aligned with where the risk was believed to be the highest.
John, I noticed you had a couple of questions. Did you want to ask those? Oh, you're off.
I gotta unmute myself. I don't know if they're. Well, I did have a question about how this. You presented several cases where the epi was positive, really, really high, but then the biopsy was without cancer. It could be, as you said, that the biopsy simply missed the cancer and the cancer was there. So my question was there a multi-parametric MRI done before the biopsy? And was the biopsy done as a targeted biopsy?
Oh, that's a great question. And there was one case I showed, not more than one, but only one, to make the point, because I don't want physicians and healthcare practitioners to assume that falsely that they set the expectation that a high-risk result guarantees that you find something, because this is a probability-based assay that was originally designed to rule out patients safely from having a prostate biopsy. But to answer your question directly, at the time these studies were done, MRI actually wasn't widely practiced. These first studies started. However, we've been looking with, I would submit that MRI, and I have a whole section on MRI. If you look at this slide, you'll see there's a button labeled MRI. So MRI and epi, I believe, and biomarkers overall, if they're a good biomarker assay, are actually complementary. And I think that's what the thought leaders in the field are coming to, is having this discussion about how you use them together. And the reason I say that is because MRI, and I'll go out on a limb a little bit, so this is my personal opinion, MRI has a much better reputation, even though it's a powerful tool. It has a much better reputation than the data supports on the negative predictive value. And so a lot of this is subjective, and there's tremendous variability. And to the point where the AUA guidelines that were just upgraded said pretty much anyone who has an MRI prior to initial biopsy, regardless of their PIRAD score, should still have a biopsy. PIRADs 1s and 2s, they said, should have a prostate biopsy, a standard 12 core, and 3s through 5 should have a targeted biopsy and potentially a 12 core on top. So I think there's room for the two of them together, and we do have preliminary data with MRI showing that MRI and the epi biomarker actually capture overlapping but not the same information. And so there's potential, although I don't have data to show you yet, there's potential to use these in a complementary way.
Yeah, I do have some comments that have come in. I'm going to share those, or questions.
That's a great question, by the way.
Yeah, Nancy says, do you prep patients for biopsy with Cipro, or use different targeted antibiotics or rectal swab testing prior to biopsy? I think this is more just a general question on the prep for a biopsy.
Well, and I'm not a practicing urologist. I'm a molecular biologist, so I don't actually treat that. I think that would probably be a more appropriate question for the urologist on the call, and how they practice.
Yeah, and I can tell you that. Oh, go ahead, Andrea. Go ahead.
Oh, I was just going to comment on this question. In our practice, we do rectal swab and send that off to look for fluoroquinolone resistance. If they are resistant, they will generally receive an injection of IM Rocephin. If not, they'll get the Cipro. And then pay attention to your local antibiogram. Thank you. Antibiogram, because that can help guide antibiotic selection for your region.
Yeah. In our own practice, we eliminated using Cipro completely. And now Rocephin is the drug of choice. And I can tell you we've had very few sepsis cases since. Did have a comment come up here from Janine Foster. This is awesome. Thank you. Hey, I can't argue that one. All right. Any other questions from our panelists for Jason?
I have a question. We know that there's disparities in prostate cancer screening and treatment among socioeconomic status, among geography, area, and race. Can you speak a little bit to the patient population in your studies and how diverse that population was?
Oh, I think that's a great question. And especially since, some of these tests that are in the same space came out of Europe, which was nothing but white European men. This study was validated in the US with a population that was designed to look exactly like the population in the clinics that you get. So it had, I want to say it had overrepresentation of African-American men. It was probably around 18 to 20%, depending on the study. So we did have what was considered a normal distribution or above normal representation of at least African Americans. I forget what the Asian and other contributions were, but it was a mixed population, predominantly Caucasian, but also with a heavy representation of African Americans. So, and we do have some subset analysis in some of these studies with African Americans, which I'm happy to talk about, or you can find in any of these studies that we've published.
We had a question come in from Susie Swain. How often should a patient get an epi done? Is there guidelines for how frequently this should be done or coverage?
Sure. Actually, this should be used, epi should be used when you're making a new prostate biopsy decision, which is typically, I've always said, that ranges from a year to maybe 24 months. But the Medicare coverage that was recently updated for the test says that it can be used once per year. So it shouldn't be used less than a year. And I would normally just say use it when, from a medical perspective, it's appropriate to do so to make that prostate biopsy decision.
Makes sense. And as often the guidelines are the coverage is based on what they're willing to pay.
Yes.
How often you can do things. Well, this has been great. Let me see if I have any other comments coming through. Looks like our audience has exhausted all their comments, which is great. That means you've done your job so well that we have nothing else to ask. I will make one comment that I'll say just from personal with working with patients over the years is that, nothing worse than diagnosing somebody with a low-grade cancer and telling them, don't worry about it. Because, and I think John could probably agree with this, patients, when they hear the word cancer, that's it. They're like, let's move on to what we need to do. And telling them do nothing is a difficult thing for some patients to accept. So I think these tests that can help to prevent unnecessary biopsies based on some of the, the side effects of having a biopsy. Plus, as you said, the other things that you don't always account for, like the emotional trauma of being told you have cancer, but you don't need to treat it. It's one of those things.
I think what's
Absolutely.
exciting about this field in the exosome field is that this is a new way that we discovered of intercellular communication. We used to think neurological or hormones, but this is another way that the cells communicate. Right now, we're using it as a diagnostic tool. I can't wait in the future of how we can use this as a theranostic tool.
Absolutely, yeah.
Absolutely.
I think for Exosome DX, the main thing that everyone needs to remember is that this test is really good when it's negative or normal or below 15.6. It's really good at telling the patients that you don't have cancer. So that when people say negative predictive value, positive predictive value, you need to translate that into common terms that people understand. When you tell the patients that this is negative, this is normal, that means the chances of you truly don't have cancer is really high.
Yeah.
Right. And I think that's a great, an emphasis is, as I said earlier, that the way to think about the negative predictive value is, or maybe I didn't say it, is for the physician to be able to tell the patient, I'm 91% certain I wouldn't find grade group 2 or higher if I did a biopsy, or 97% certain I wouldn't find grade group 3 or higher if I did a biopsy. That's how I usually talk about what a negative predictive value means. But you're right, that is the strength of the test, is to help suggest which patients don't need a biopsy, and the ones that we tee up are more likely at risk. But as I spent some time, there's no guarantee you find something.
We have our last question that we'll take for the day. Susie said, how quickly do you get the results? That's a good question. What's the turnaround
I would
time?
say don't quote me 100%, but I want to say it's somewhere around 3 to 5 days from the time that they send the urine in. It's a very quick turnaround time where it's really limited by FedEx delivering the urine sample, collecting it at either from the patient or from the clinic, and then once it gets there, is probably about 3 or 4 days max. So the answer is very quick.
Any special packaging, heat concerns, or?
It does come. The box contains ice packs to put the urine on, and there's specific instructions so that hopefully it doesn't, if you're going to ship, you can store it in the fridge until you're going to ship if it's over a weekend, so that you're not going to put it there at some point where maybe it gets stuck while the lab is closed or whatever, or for holidays. But yeah, we just like to keep it cool.
Good. Another benefit of this test is that you do not, or the practitioner does not need to perform a DRE before the urine expression or the urine collection.
Yeah, I like to be able to send it home with the patient idea too. I
Yeah,
think
that's
your client-
actually, I used to talk about why couldn't we do this at home for a long time, and there was no movement because it takes work to validate, to show. And then COVID came along, and all of a sudden this was a priority. And so it really was only because of COVID that we looked into it. And during COVID, some of our doctors, or a lot of our doctors, were using it to triage who would come into the office, because they only wanted to bring the patients at higher risk.
All right. Well, great. It's been a great discussion. Appreciate all the help from the panelists. And Jason, it was a great talk. I do want to give a plug here for next week's talk. It's going to be from Sandy Brunello, who's going to be talking about a unique, innovative, non-invasive, leak-free solution for urine collection in women called the UroCap Female. And for those of you that didn't get enough or have some more questions or just want to hang out, we do have the after party again. Go to euronurse.com, click the button. It'll take you to a Zoom meeting where you can go ahead and chat with everybody. Maybe you're thinking about being a panelist. That's a good place to talk to us about that. So once again, I'd like to thank my panelists. It had a really great show and enjoy seeing everybody. If you're not coming, enjoy your day out today. It looks beautiful weather today. Have a nice day, everyone. Thank you.
Thank you, Jason, for the presentation.
Thank you very much for having me. I appreciate it. Bye, everyone.